This is a video interview with Josh Wright, who's a consultant haematologist and the immediate past president of BSH. And my name's Stephen Hibbs. I'm a haematology trainee from East London, and I'm really grateful to have this opportunity to ask Josh some questions. So just to start with, I guess, can you take us back and tell me what was the moment at which you decided you wanted to be a haematologist?
I think possibly it's not so much a moment as an individual. Role models are, I think, underestimated and just a really important play really important roles at various points in your life, whether it be a professional life or otherwise. I did first exposure to haematology was on an elective in Australia when I went out there with a colleague. So I was a fourth year medical student, and the only person who took any interest in us was a haematologist. And he gave us some teaching. He also bought cake and coffee and gave us the afternoon off to go to the beach. So I thought this sounds like a really good specialty. I shall think more about it. At the time, I was not particularly enjoying my medical education, and in all honesty, struggling a bit with the medical course. It was, it's just a sort of repeated set of educational hurdles and exams to get through. And I went back to Sheffield, where I was a student, and I thought, right, I'll intercalate. I'll do an intercalated degree for a year, which was quite unusual at that stage. And I went to see the haematologists, just sought the haematologists out, and the guy I ended up speaking to was Mike Greaves, who is a former president of BSH, and really, to be honest, he was fantastic. He was a relatively new consultant at that stage, and he sort of behaved in a manner that I really admired, and sort of felt like the haematologist I'd like to be, and the doctor I'd like to be, perhaps more important at the time. So really, once I'd done my intercalated year and research project in fibrinolysis in normal human pregnancy, I felt pretty convinced that haematology was the specialty for me. And then I went through, as you do, a series of junior doctor jobs, which I made sure included a role in an SHO, as an SHO in a haematology department, sort of perhaps F2 as it would be now. And that didn't convince me otherwise. And so once I got my MRCP out of the way, I opted very quickly to, after a short period as a medical registrar, to take specialist training in haematology.
Just going back to the meeting with Michael Greaves, is there anything that that kind of just comes to mind in terms of what was it about him that drew you? What was the kind of part of the way he operated as a doctor that made you think that's the sort of doctor I want to be?
Well, he was very much my senior and my better, but he never treated me as such. Really, he was very open and approachable, considered in his responses, and a warm human being who demonstrated warmth with those that he was clinically involved with and his patients as well. So I think it was there was that humanity, I think, that I warmed to. And made me think this is how medicine should be practiced, I guess. But he's also highly academic, very bright guy, and gave me very good advice and time as a kind of student trying to find his way into laboratory issues in haematology. And there was also a great hemostasis laboratory in Sheffield at that time, and there still is. So it was just a fantastic place to be as a student, and they weren't used to people coming to do haematology as medical students in that way at the time. So yeah, I benefited in many ways.
And around that kind of early time when you're beginning to train as a junior doctor and then maybe as an early haematologist, are there any kind of particular patients who stand out as memorable encounters?
Well, in that I mentioned that I was in Birmingham as an SHO in haematology. So I was a brand new SHO, first SHO post, small DGH, and largely, as you were in those days, unsupervised, no registrar, and there was a young woman who had accelerated phase CML, which rapidly became AML, and this was in the days where TKIs were not yet in routine usage. In fact, they weren't even in early, well, they're probably in early trials, but at that stage I wasn't aware of them. And so there was really little or nothing that we could do for this poor woman, the young family. And I think I was so keen as this brand new haematology SHO that she did well. I probably did not, perhaps should not have been allowed to communicate as honestly in the way I did. And I probably left her with unrealistic hope. And when that did not transpire, as was often the way with transformed CML in those days, I was heartbroken. I really felt that I had let her down, her and her family, by the nature in which I had discussed things. And I think she said to me, not long before she died, you said it was all going to be all right, and I just felt absolutely awful. And it taught me a lot about the difficulties of communicating with patients in difficult situations and their families, and how a compassionate honesty is absolutely crucial, and that bad communication is both in a non-compassionate way or indeed in terms of raising unrealistic hope, either of those is just as harmful. So she was a very memorable patient, taught me a lot about painful lesson in early communication with patients, I think.
And I'm kind of struck just hearing the story that I started my haematology training in 2017, by which time CML, all of the kind of huge breakthroughs had really happened, and I maybe learned about them even in medical school. And I just, especially with an experience like that, what did it mean to you and to others in the haematology community when those early results about imatinib started coming out?
Yeah, I mean, I suppose I've been lucky enough overall to work in a period of time where haematology had changed, relatively little in terms of the drugs that were available for a reasonable period, and there's just been this enormous revolution in targeted therapies and biologics, which has just been an absolutely fantastic time to be a haematologist. And you're right. I mean, CML was a disease with a very poor prognosis. You managed to control it for a while, and it then became more aggressive and transformed, at which point there was very often little you could do. So having a drug like imatinib to use, a tablet, that actually change people's lives and outlook completely in such a massive way was huge. And hot on the tail of the TKIs came the first monoclonal antibodies, rituximab in lymphoma, and so these things made very significant changes to people's outcomes, and the manner, the optimism that you could feel when managing them, because some of the diseases we look after are pretty dark and desperate sometimes. And so it's great to have this armamentarium of targeted agents and biologics that we can use and take for granted somewhat now. Yes. So yeah, I'm a bit of a historical relic possibly.
That's great. And I'm interested as well in, I know a lot of your career has been focused on global haematology and particularly supporting colleagues in lower middle income settings. Where does that part of your kind of story and your work start? And can you tell us a bit more about that?
So I suppose it comes through the sickle cell line, the hemoglobinopathy line, and how I ended up being interested in that. You wouldn't have thought Sheffield necessarily was the epicenter of sickle care in the early 1990s, as it was when I was a registrar. And it basically, our senior consultant had to put together the seminar series, and all of the registrars got asked to deliver a topic of their interests, and I was asked what I wanted to talk on, what I found interesting, and I sort of said, well, I find everything interesting, to be honest. I'm not really sure I could pick anything. And he said, well, clearly getting irritated with me for not having a focus. Like, you can do sickle cell then, because nobody else wants to do it. And I took this on, and I was absolutely fascinated by this disease, which ostensibly appeared to be so straightforward on a molecular basis, yet the knock-on effects were so complex. Had I not delivered that sort of regional training at a relatively early stage, I wouldn't necessarily have been so attracted to the MRC sickle cell unit job that came up not long around the time that I'd passed my sort of first parts of my pathology exams, my FRC path exams. And I applied for that job, and as a consequence ended up going out with my wife and young family to Jamaica for a couple of years, working with Graham Sargent in Kingston. And that was just an eye-opener, both from the point of view of understanding about the sickle cell disease, which was absolutely as fascinating as I had felt it was when I was just reading about it, to seeing the impacts of poverty and poorer healthcare systems on the effects of disease. So yeah, very important period of my life for good reason. Although I've always wanted to be more involved in global issues, it's actually BSH that's given me that opportunity. I think you come back, you then have to establish yourself in a consultant career, and you have a young family, and all of that takes huge amounts of time. So it's actually only latterly, as the family's got older and getting involved with BSH, that I've got back into global haematology. And of course, I'm now able to. We've got a project, an evolving project in Zambia that I'm still working on, and I've been lucky enough to go to Bangladesh, mainly around screening. For hemoglobin disorders, population screening for hemoglobin disorders. So really fascinating, takes you to different places. You have to think in a different way to the way you do when you're on the ward. It brings in all those attractive bits of haematology, the conjunction, the sort of meeting points between laboratory practice and clinical practice.
Yeah. And I know that in the last few years you've been very involved in leadership in BSH, but even prior to that, I know a lot of your career has involved leadership in a medical leadership position. Can you say a bit about how that came about, and some of the influences that led you to be involved as a medical leader?
So my first consultant role was in Birmingham, and I was lucky enough that they needed somebody there to develop a sickle service, a sickle and thalassemia service. And I had huge support both from the community and the trust at the time to do that. And it was an enormously satisfying period of 3 or 4 years where I was able to develop this service with all the weight of a trust and a community that needed this doing. So it was actually quite straightforward to do, but very, very satisfying. So I very much enjoyed leading that process, and then I ended up in Sheffield, having moved there in the early 2000s, and more by default than anything, and was head of department quite quickly. And I think you find yourself, and it wasn't quite so straightforward becoming head of department, larger trust, not quite such a particular burning issue that needed sorting. So you find yourself in these positions that I think possibly you are unprepared for. And I took a diploma in medical leadership at Birkbeck and with the Royal College of Physicians over a couple of years, which I think taught me quite a lot about organisational culture, team culture. It was more of an organisational psychology course, I think, than anything else. But it taught me that taught me to think of things differently in terms of interaction with individuals. So. And interaction with other teams. So I always try and think. So you meet behaviours that patterns of behaviour that you can't necessarily immediately work with, and I think I always try and take a step back and think, why is this the situation, and this isn't personal. I think was also an important lesson, really. So there was understanding around. The psychology of human interaction and team interaction, and the importance of culture in organisations that really came to me from that period of time, which I then took into head of department and then clinical director for a specialty grouping within the trust, which I must confess I found harder, because by then you'd moved away from making developments that you could see a benefit of for patients, and it was more dealing with difficult personnel issues and bad behaviours and underperformance that I found much harder to deal with. And it's actually when I stepped away from that and was looking for other opportunities that that the BSH role as a trustee became available, and I applied and was successful, and have really thoroughly enjoyed working in an environment where you sit around a table with like-minded individuals, not necessarily all agreeing with on the same topics, but essentially people coming from the right direction, and with a bit of infrastructure and support, financial support behind you to make things happen very quickly if you want to do them, if they're felt to be a good idea for the society and the profession in general. So it was a very positive experience moving to BSH, I never really considered I'd end up as president when I started all that.
So can you say a bit from that sort of period where you're first joining and getting involved as trustee? What were some of the highlights? What were some things you really enjoyed in that time?
I think it was initially it was the contrast between trying to work in a trust where your medical management teams work from a different set of rules to your clinical teams, and trying to align those sort of two sort of circles on the Venn diagram to allow things to improve for patients and clinicians alike, and that was just always a bit of a battle, and I think moving to BSH, seeing it was a point the organisation was had developed a strategy the first time for a number of years, had some key priorities that it wanted to target, improving the ASM, amongst other things, which had become a sort of shadow of its former self over the previous few years. So there was a clear vision and a clear aim, and the people around the table, both haematology trustees and lay trustees, who brought a huge amount to the discussions, that just felt really powerful, and quite quickly we started to sort of turn the organisation around, really. So a thoroughly positive experience.
And then you did end up becoming president. What's that like? What do you do when you're a BSH president?
Essentially, you are. So there is already a strategy. So you can't come in and go, that's all fine, I'll just do what I like now. You have a strategy that has been set by the society, and you're really, I suppose, steering that ship, if you like. It's not about personal. It's not. You can bring your personal slant to it, but it's not about your own personal aims, really. But I thoroughly enjoyed it. It's a very, I really enjoyed sitting around the table with the various trustees that I've worked with over the years. As I say, I became involved both with the Education Committee and with the Global SIG, and did quite a lot in terms of setting up the programmes for the scientific meeting, which you were very aware of because you were highly involved, thoroughly positive experience, and I'd probably regard it as a career highlight, to be honest.
And is there anything, I guess, now you've finished your term as president, is there anything that you, I don't know, just look back on with particular kind of pride or particular pleasure that happened during your involvement with BSH?
I actually really enjoyed, not the first time around, but I was very heavily involved with 3 annual scientific meetings, and actually the last one I really enjoyed. Is the highest, you can see the effects of your efforts, of the team effort, working with Chris Daly as chair, the highest number of people attending a meeting, probably the best level of sponsorship we've seen. So it really felt like a reward for the labours of the previous years. And I'm also very proud that we managed to think a little more widely and ambitiously in terms of the strategy for the society, taking on a greater advocacy role, the workforce study with London South Bank University, hopefully will be a stepping stone for us to play a greater role in trying to assist the haematological community to take its steps forward. We don't, as haematologists, it's obviously, to you and me, we know it's the most important specialty in the hospital. You can't come into a hospital without a haematological intervention, whether it be a blood test, a blood transfusion, or at the very minimum, heparin prophylaxis. So you know, everybody has an interaction which is haematological, and there's this sort of range of fascinating diseases that you're dealing with, but we fall between too many stools. So we're neither a pure lab specialty, nor a pure clinical specialty, nor a pure oncology specialty. So we get missed out. We punch well above our weight as a specialty in terms of what we deliver, but in conversations and policy, we fall through the gaps. And I think one of the my strong wish for the future of the society is that we persist in raising the profile of haematology in those areas to make sure we do not get neglected. We're very good as a specialty, and I see it in my colleagues, and I see it across the broader range of teams in haematology. We're very good at just absorbing work because it needs to be done, and not actually making enough of a fuss about what's being done. So, liaison haematology, for instance, huge workload, completely unquantified and uncounted. Yeah.
Looking back over the whole of your career, I'm wondering, have there been any particular moments that have been challenging, or where you've, for a period of time or in a particular encounter, just been thrown off a bit by something that's come up, either in clinical practice or in a leadership role?
Yes, to both of those, repeatedly. I think in a managerial role, when I became a clinical director and I was dealing with poor performance and difficulties within teams, dysfunctional teams, I found that extraordinarily challenging. I think probably as an individual, I would have been better off being a slightly harder individual to deal with it. I took a lot of it home. And also at the time I had not cut down my own clinical commitments enough to actually do the job without cost to myself. So that actually was a difficult period. In terms of clinical interactions, I think it's hard to pick out. And we talked about the early case around communication. I mean, we as a haematologist, if you've been a haematologist for many years, you inevitably acquire a range of experiences with cases where things didn't always go absolutely perfectly. And I think one of the things we're probably not very good at acknowledging or talking about is the cumulative effect of that. So I'm not going to pick out one in particular, but I think if you take into account that every one of these very difficult cases, particularly if it doesn't go according to plan, or complaints or coroner's court appearances, all of these things, I think each of those takes a little bit of you away. And there is a cumulative compassion fatigue to the practice of haematology and the difficult diseases that we manage that should not be underestimated or unacknowledged. And as I reach the end of my career, I definitely feel that is something we need to talk about a bit more openly, in all honesty.
And I guess on that, and some of it might just be there's not much you can do about it other than those scars or those burdens stay with you. But is there anything you've noticed that restored some of that compassion for you, or I don't know, did something to take off the load of the fatigue for you?
I think, but your colleagues, you go to work because of the specialty and because of your patients, but actually you also go to work because of your colleagues. They're the ones that take those pressures off, and your family as well. But sometimes it's difficult to articulate these things fully at home and the full impact of them. So, but I think definitely, working as part of a multidisciplinary team and having the support of good colleagues is undoubtedly crucial.
And if you were going to have some words for someone, kind of a new trainee coming into haematology who's hoping to make an impact over the course of their career, and I don't know, what would be some of the encouragements you'd want to pass on to them?
Well, I do hear people saying, "Oh, I'm not sure I advise my teenage child to go into medicine anymore." I disagree. I think it's obviously the NHS as Lord Darcy has articulated very nicely, is not in a great place at the moment. But that's not to say that health provision and medicine are not good things to go into. And that's certainly not to say that haematology is not a good thing to go into. It's still an absolutely fascinating specialty. You know, I still find things to be fascinated about on a daily basis, practically. So if you want continual challenge, continual development, then do it. Don't be put off by the extra exams. That's just part of the process. I'd also say that you know, don't be afraid of sticking your head above the parapet. You might get things thrown at you occasionally, but on the whole, being brave, but having the courage to put yourself forward into a position in which you might fail, it has generally served me well. And do not think that you're doing this on your own. You know, collaboration with colleagues, collaboration with other departments across the country or within your own institution is tremendously empowering and rewarding. So I think I've had a marvellous career. I wouldn't change it at all.
Brilliant. Thank you, Josh. Is there anything else you want to say to finish with?
Well, no, thank you, Stephen. Thank you. Well, actually, one of the things I would say is that one of the high points, I think, is actually dealing with trainees. And I'm here talking to you, and I've really enjoyed working with you in the programme committee, and your kind of very interesting slant on things and your multitude of talents, which rather put everybody else's in the shade. And actually being involved with trainees on the way through my career has also been a very rewarding and enjoyable part of it. Yeah, I'm not sure that the people I've supervised would say my knowledge of the portfolio or handling of the portfolio are necessarily perfect, but I think, you know, to be in a position where you can mentor and support is a tremendously rewarding thing to do. So that's it, really.
Well, Josh, thank you so much for this time, and thanks for all you've done in haematology and for BSH and for this conversation.
Not at all, Stephen. Thank you very much for interviewing me, and thank you for taking the time to do it. It's been a great pleasure.
Thanks. And for everyone watching, you may have noticed there is road noise. We're in the BSH HQ. There's a road outside. That's life, I guess. Yeah, thanks for watching.